So let's start the official session. The first speaker is a paradigm on his own, Dr. Tayyab. He's a FCPS, FRCOG, FACOG, MRCPI, FRCS, MCPS in Health Professional Education, and a FCPS from Bangladesh. He is a current professor and Dean of HOD and HOD of Obs Gynae at Al Alim Medical College, Gulab Devi Hospital since 2019. He is the sitting counselor of CPSP since 9 years. He is the past principal of Amiruddin Medical College, a past president of SOGP, and past member of IRC RCOG committee in Pakistan. He is currently a member of ASHR and ASRM, a IVF clinical specialist at Life Lahore. Ladies and gentlemen, please put your hands together for Dr. Tayyab.
Right. Assalamu alaikum, everyone. It is very difficult to speak to an audience who's so learned and varied and experienced with such a broad depth of professionalism. I'm very grateful to Professor Shaheen Zafar, who honored me and invited me from Lahore. She called me about a month ago and she gave me this topic and I said, oh my God, what shall I do with this topic? And she said, ये मुझे पता नहीं तुम इसके साथ करोगे क्या, लेकिन अगर तुमने मुझे बोर किया तो मैं स्टेज से खुद उतारूंगी 5 मिनट के बाद और एयरपोर्ट छोड़ाऊंगी. Is madam here? So मेरी इतनी जान निकली कि मैंने थोड़ी सी एफर्ट इसके ऊपर की, but I tell you what, this was a great learning experience for me as well, just to prepare this talk. It always is. Future vision or future strategies in obstetrics and gynecology. And I also thought there's so many different ways to approach it. Are we talking about future in the world? Are we talking about future as a profession? Are we talking about our own realities in Pakistan? Are we talking about individuals? Are we looking at social or professional angles? What are we looking at? And I stumbled upon a lot of literature, and a lot of literature also that has varied pre-COVID and post-COVID as well. And this was a good paper that was published in the American journal, The Future of Obs and Gynae in 2020, a clearer vision why a change is needed. The one thing that any professional evolves is change, and as you're well aware that change is always something which is inevitable. There was a movie I saw called The Blue Lagoon, and there was a dialogue in that which says, this is 1918, times have changed. So I guess humans have all through centuries told each other, times have changed, and they keep changing. This, I think, was the gold dust I was able to touch. When I was looking through the literature, I just found this is Clinics of North America, and I started looking for this book, and I think most of the lecture that I have built up is from this text, and the references in this text. It was a wonderful treatise on the vision of and the future of Obs and Gynae. Like I said, there's so many different things we can talk about, but the things I am going to talk about for a couple of minutes each is simulation in Obs and Gynae, screening in cancer, contraception, sub-specialization, fetal surgery, robotic surgery, social media superpowers, a bit about infertility treatments, and lastly, one topic which is close to my heart, which is burnout for us and for our youngsters in obstetrics and gynecology. What is simulation? Any physical object, device, situation, or environment where a task or series of tasks can be represented realistically. That's what basically it is. Procedural simulation like shoulder dystocia on a pelvis and cloth baby, and full immersion clinical simulation like several team members on a simulated patient or a mannequin. And a lot of research now has confirmed the advantages for things like shoulder dystocia and PPH drills, as some of you have attended the also workshops, and we've got MOE and PROMPT. It's all on simulated models, but the idea basically is to look at this. This particular model is lying in a very famous world museum called the Louvre in Paris, and some of you must have seen the Louvre. It's lying there. It's the machine obstetric simulator of Madame Coudray, and this is from the 17th century. And so people started thinking about simulation way back in time. Actually, the first historical records of simulation came in the 9th century, and then humans kept quiet for the next 6 centuries. And then in the 17th century, we started getting wooden birthing and pelvic models. And then simulators called phantoms were made by the father of British midwifery called Smelly Wheat, William Smelly. He was a Smelly Wheat maneuver person. And now we know that simulation is the mainstay of safe patient care across all disciplines, like laparoscopic surgery and robotics and so on. And research has confirmed that if you go through simulation, it definitely confirms improvement in teamwork, communication, and it advances medical knowledge. And simulation types are low fidelity versus high fidelity, and any simulation session is a pre-brief and a simulation process, and then debrief. And these are different types of simulators, like you got a task trainer, a full body mannequin, a hybrid, and virtual reality. And a lot of neurosurgeons now do look at a lot of virtual reality because of these confined spaces within the cerebrum. VR has come in a big, big way. And VR has come in a big, big way in academic teaching as well. Hello? Can you all hear me? Okay, better. So VR has come in a big, big way. But simulations, as you know, the simulator, the mannequin itself, they have evolved over time as well. And this is called the Noel. It's a full patient mannequin with a motorized mechanism for pushing in labor. Obviously, this costs about $90,000 US. American board in Obs and Gynae recognized laparoscopy in 1971 as a tool. And now fundamentals of laparoscopic surgery module is mandatory training for anybody who goes through training in Obs and Gynae. Then this German person called SEM, he invented the simulator in 1985. It was a lab training device in a box trainer. And today there is a heavy reliance on computer programs which mimic real life, like modified beef tongue models for 4th degree lacerations, and simulators for sonography, for forceps, for CVS, for amniocentesis, and others. And there are ovine models available for robotic hysterectomy. And these are some of the simulators which are currently available around the world, like the Victoria obstetric simulator, like the operative experience. An operative experience simulator basically is for very difficult vaginal births and operative instrumental deliveries. Mama Natalie hybrid birth simulator. This is a hybrid in which a patient or a simulator wears something on top. And it's got that capacity to make as much blood as you want in terms of hemorrhage and so on. And this is used increasingly in many American programs. And Prompt, as I already mentioned, I think you're familiar with Prompt and you're familiar with MOE. And virtual reality has come in a big, big way. This is the Lab Mentor simulator from 3D Systems using virtual reality. And it's a total immersive experience. And you know that virtual reality is used across other disciplines like for pilots and aircrafts and those things as well. And then a company called Syndaver Cadaver, Florida. It costs 60,000 rupees, but it's so good that I read about that. It mimics actual cadaver tissue, so you don't need to get dead bodies anymore. It will mimic layers, it will mimic blood vessels, it will mimic nerves, and you can go and dissect through that. It's very, very interesting, Syndaver Cadaver. And then in terms of evaluation, the simulation, the Kirkpatrick's 4 levels of evaluation has also proven a lot of good data to say that for obstetrics and gynecology, the future is simulation. Level 1, how participants feel after simulation training, and that is done by confidence scores and surveys. Level 2, how knowledge or skill performance tests and assessment of skills is done. Level 3, did the workplace behavior change? Did it happen? And that is done by audit in clinical sites. And level 4 is organizational benefits, like improved patient outcomes, the ultimate goal of simulation exercise. Now, a little bit about screening in cancer. And in screening in cancer in the US, because this book was US and a lot of data was from there, 10 to 15% of all cancer in women are gynecologic. And the future of gynecologic cancer screening lies in less invasive, patient-centric, biomarker-driven screening. Like, I was very amused to hear that now they're looking at simple urine that you pass and a lot of biomarkers which you can pick up from the urine. You don't even need to take a blood sample. Endometrial cancer, we know that type 1 is 80 to 90% is preceded by a less severe variety, and type 2 is much, much worse. We know what are the preventions, like POP and combined pill, and if BMI is over 40, you reduce obesity, including bariatric surgery and so on. And the guidelines of ACOG says that if TVUS shows a 4 millimeter thickness, you do take a biopsy. And urine for biomarkers, urinary cell-free circulating tumor DNA is a lot under study now, and maybe it will be clinical practice perhaps 2 years from now. And they're also looking at other ways of looking at collecting samples rather than doing just a pipelle, including tampons, including brushes and other things, and that is underway now. Ovarian cancer, lifetime risk is 1 in 78, but it is the deadliest form of cancer. And inherited variants like BRCA1 and 2 suggest that the risk-reducing salpingo oophorectomy is definitely one of the options to go for if somebody's got BRCA1. And screening in low-risk women does not reduce cancer mortality, but it can result in harm from false positives. So this has to be taken with a pinch of salt. So there are no effective screening mechanisms. And as you can see, several new tumor markers are being studied to look at the risk factors. One comment on cervical cancer is way back in 1942 when Papanicolaou first described the cytology for cervix. The HPV vaccine was approved in 2006 in the United States for age 9 to 45 years. And the American Society of Colposcopy and Cervical Pathology 4th guidelines now recommend HPV-based screening every 5 years. Cytology-based screening 3 years, but HPV-based 5 years. And in the future, coming back again, self-collected urine-based HPV, so probably that need is also going to go away. And large screen HPV vaccination will have impact on future screening protocols. These are some of the commercially available FDA-approved PAP virus tests, and sometimes in Pakistan you get a test that is available and then it goes away. Third topic for future is contraception. And many new things and very exciting things have happened in contraception. In a country like Pakistan, where CPR is still 35, obviously it's the need of the hour that we look at everything that's possibly available. Nuva ring, these are contraceptive vaginal rings, or CVR, and Anovira, they are now in use, inserted within 5 days of menses, removed for a week after 3 weeks. And then there's a progesterone-only ring with the progesterone called trimegestrone, which is under study and is not launched yet. And ulipristal acetate, as you know, is an oral contraception license for 5 days after intercourse. And that ring is also under review. And then a non-hormonal CVR, which is Ovaprene, is a knitted polymer barrier to impair sperm, and that is also now available. These are images of Nuva ring and Anovira. And they look like a pessary that we use for prolapse, but very similar to that. What about transdermal patches? They have been around for a while as well, although not available in Pakistan. But Ortho-Evra and Xulane, they both contain ethinyl estradiol and norelgestromone, and a patch called Twirla. Basically, you apply on the buttocks, upper arm, lower abdomen, and you apply a new patch for 3 weeks, and you take it off for a week. And the only caveat here is that obese individuals over 90 kilograms, it may lower the efficacy of the patch. What about other contraceptives? Mini pills, the so-called progesterone-only pill, the only problem with that is you have to take it the same time every day. And the window, what is called the window, is a 3-hour window. So if you miss a pop for 3 hours, you need to take 2 of those. Slind is a new one. It's a 4 milligram drosperinone-only pill for 24 consecutive days. And the advantage with this progesterone-only pill is that your window is increased from 3 to 24 hours. And then it's very interesting, non-oxynol, spermicide non-oxynol 9 was available always as a spermicidal gel. But in 2020, FDA approved a new exciting thing called Phexi. It's a gel with lactic acid, citric acid, and potassium biotartrate. And just push in a little bit of gel, comes in a packet, and there's got 10, 15 sachets in that. And just take it out and use it, and you're done and you're sorted. Sorry. What about implants? I think some of us have familiarity with implants. Nexplanon is a single rod etonogestrel. Implanon, according to the international data, is now obsolete. I believe Implanon probably still is available in Pakistan, but I think probably now, okay. And Jedel, using for 5 years, and Sino implant for 3 years. Now, one of the things that I was going through the data, and I said, okay, how safe is it for you? Can everybody use it? They said, do not use it unless you've been trained well, because serious neurovascular injury is a known complication if you're doing it in the groove that you're not familiar with. So it's important that you know what you're doing. What are the new intrauterine contraceptives over the horizon? Well, Mona Lisa copper T. Mona Lisa is a new copper T. It's available for 5 years and expects to be more efficacious. Viracept is a smaller size one. And ballerine, this is ballerine. It's like a mesh. It's like an intrauterine ball, 3 sizes, 12, 15, and 18 mm. And what they say with ballerina is that it's got less cramping, lower perforation, and efficacy is 5 years. And then a couple of more frameless IUCs, just put in there and they stick there, like a Gynefix and Fibroplant. It has the same kind of size as a levonorgestrel, but some people say you can use that as an equally effective contraception. Last comment on upcoming in contraception, now you're going to get contraceptive jewelry. So you can have a necklace, which is actually contraception. You can have a ring, which is actually contraception. You can have a chudi, which is a contraception. You don't need to tell your partner this is a contraception. Just wear, I love wearing my necklace. Okay. So it is for use for 16 hours, and then you can take it off for 8 hours, and it will mimic jewelry because nobody is going to suspect you. You don't need to wear it 24 hours. I thought that was a wonderful idea, whoever thought of it. Oral gelatin capsule, once ingested, expands in the stomach and stays there for 3 weeks. That works. Biodegradable microneedle containing skin patches. You just put the patch, take the patch off, nobody knows. All done. Multipurpose prevention, CVR, levonorgestrel, and tenofovir to prevent HIV, because the problem with non-obstructive things is that you can get HIV, so you can use that. And then in the future now, over the next couple of years, they are going to teach us how to self-remove an IUCD, so you don't have to go to the healthcare provider, and that is coming. Next comment on sub-specialization in OB-GYN, and you all talk about it now, and it's very important. Obs and Gynae became an accredited specialty in 1930, and at that time there were 13 medical specialties for doctors. Subspecialties began in 1972, and worldwide about 5, 6, or 7 subspecialties are now available. In the United States, 1 in 4 residents applied in 1 in 4 residents apply for it now at this stage in 2021, and 1 in 12 residents used to apply in 2001. So within 20 years, many people want just to do subspecialization. Now the problem that has come in the developed world is that there are so many specialists or subspecialists that people who do general obs and gynae are dwindling, and that is a problem in the masses. So you have to keep that kind of balance. What are the American Board of Obs and Gynae approved fellowship years? It's written up here. I think you're all familiar with them. And then there are certain non-ABOG fellowships as well that are available. Fellowship training options for applicant. This is the last slide, and this just shows how many years. Some have got 2 years training, some have got 3 years training, and I think all colleges and all countries make their own set. Next topic is about fetal surgery, and this was very illuminating for me because I had just read it as an abstract, as a idiosyncrasy of somebody. But presently, invasive procedures correct or ameliorate congenital anomalies before birth, usually by a procedure called fetoscopy. In the future, there'll be robotic surgery, and the new name for that will be phebotics, combining fetoscopy and robotics. Fetal membrane repair is the main problem. The problem is whenever you cut open a uterus and go in there, the injury that you will leave behind is the fetal membrane. That is the Achilles heel of fetal surgery. It has always been there. So what to do with patch or adhesive or anchoring sutures? And then a bit about in utero stem cells and gene therapy, ex utero support, and IFMSS is the International Fetal Medicine Surgical Society. And about over 1,000 fetal surgeries are performed in the United States every year, 1,000 per year. What are the kind of team members that you need for fetal surgery? All these are team members. You cannot begin a fetal surgery program unless you have a clinician, a researcher, a geneticist, an ethicist, ancillary support, and support for the family. The first open fetal surgery for obstructive uropathy was done as far back as 1981. And then the MOM study, which was conducted in 2011, it confirmed its benefits. And from then it really took on. The problem is whether you want to do a laparotomy and then reach the uterus, or you want to do it percutaneously and take a scope in. That is where the debate is, because where would you injure the membranes most? The commonest complication in minimally invasive fetoscopy is insult to fetal membranes, resulting in either prom or preterm birth. The order of invasiveness of a fetal surgery is open fetal surgery, ex utero intrapartum treatment called EXIT, minimally invasive fetal surgery, especially robotic surgery, ultrasound guided procedures, and efforts. Now, the future is basically how can you use a shorter operating time, smaller equipment, less maternal anesthesia, balance between fetal and maternal risk. Because if you're doing something for the benefit of the baby is still inside the mother. You cannot endanger the mother in order to save the baby, and that wouldn't be on. And therefore, the procedure is decided on the fetal condition and experience of the surgical team. Okay, just a couple of slides. Stem cell, although they are being done in stem cell therapy is being done in very small cities and towns of Pakistan, but in the world it is still experimental, so we need to understand that. Stem cells harvested from allogenic donor, grafted into developing fetus to replace cell lines, and congenic stem cells from fetus itself. So two ways. Why will the fetus benefit from stem cell therapy? Because fetus has got a small size. Fetus has got an immature immune system which can be trained, and there are multiple large populations of undifferentiated cells where stem cell is going to work. What about gene therapy? Also experimental. It's done by intraamniotic administration, penetration through all the 3 germ layers during embryonic folding, using viral vectors, particularly adenovirus-like capsids. And the 3 diseases in which it is confirmed to be beneficial is Wilson's disease, myopathies, and hemophilia. Fetal immune system learns tolerance to these viral vectors very quickly, and then there are other gene splicing pathways in order to do that. One last thing about this is artificial womb, and this also is very interesting for me. You take the baby out, and you place it in such a way that you can have support once the baby is born. Right, I'll quickly run through the remaining, I've got 5 more minutes. Robotic surgery, despite controversies, it continues to grow and expand. It is far superior in ergonomics versus laparoscopy, but the hospital privileging is very variable. The Da Vinci system, the Da Vinci system from 2001, I think it cost $100,000, $1 million in the beginning. And various systems have progressed over time. And what is the progress? Of all hysterectomy in the USA, robotic surgery was 0.5% in 2007 and 25% in 2022. That's just a change, and where are we? In Korea, it didn't go that much, but in worldwide increase in 2015 is 20% increase per year. And new studies have confirmed versus laparoscopy, shorter operating time, shorter hospital stay, less blood loss, less post-op complications, and so on. Da Vinci systems, other systems like Senhance, Hugo, Tava, Versius, and so on. But this is basically a comparison of ergonomics. This is a surgeon who is doing a robotic surgery, sitting, sipping coffee, moving fingers and hands and wrists. And this is a surgeon doing a laparoscopic surgery. A couple of people whom I've spoken to say कि जब से मैंने robotic शुरू किए मैं थकना बंद हो गया. That's the good news. Future refinements, last comment. We're looking for robotic surgery, progress in which there is cost-effective surgeon ergonomics, better visualization, haptic feedback, that you move your finger and you can feel the touch, reduction of overall footprint so that the large pieces of equipment needs to be reduced, decrease the size of incision, and combining virtual reality and artificial intelligence into the system. 7th, social media superpowers. And some of us are not very good doctors, but we are very rich millionaire YouTubers. And sometimes I feel really small that I don't even know how to operate my phone. So I have to ring my son up, can you please put my phone on? But social media term was first used in 2004. Now there are over 4 billion of the 9 billion world population who use it. And the people who use it for 2.5 hours a day. It's a ubiquitous form of communication. Patients rely on social media for support in community and health. Doctors have a duty to provide this, and we should be aware of that. And telemedicine is probably the future, and people have learned that post-COVID. This is just a graph to say how many billions of users are using the social media in this sequence. And basically the takeaway from me was that perhaps every doctor should have some familiarity or usage of that. But what you need to do before you put something on the post, what is the purpose of this post? Does it engage my audience? Does it align with my voice or brand? Is there anything negative about patients or colleagues? Is there anything that could be viewed as offensive? Do I feel okay? And are there any HIPAA violations, which is the federal law in the US, Health Insurance Portability and Accountability Act, that you don't violate people's interests? Second last, infertility. I'm not going to talk a lot about that because I think the conference is all about infertility. But you talked about laparoscopy, we've talked about uterine transplantation that's coming up. IVF, 4 decades have been completed, and this is the future. Incremental optimization of existing techniques and development of new disruptive technologies. So there's going to be a lot more artificial intelligence, AI, and stem cells in the future. So you have to rise above the current challenge that is there. I think I'll just drop that. And I just finish with this. This is, again, a topic very close to my heart and myself and my colleagues. You know what? You have a very grueling life, and then you get home, and the last thing you want is an argument or something at home. So this is something that you have to look after yourself. You look after yourself, only then you'll be able to look after your patients. And what is burnout, basically? A constellation of emotional responses, a loss of enthusiasm for work, feelings of cynicism and depersonalization, and a reduced sense of personal achievement, even after you've achieved so much in life. And it's very important, and therefore, I think sometimes our trainees begin to feel that in year 2, 3, and 4, and sometimes we feel to begin that in different times of our life. And I just wanted to share a little thing with you, which is the National Physician Burnout and Depression Scale, which was published in 2018, and it was mind-boggling to see where the ONG is. Which physicians are burnt out? Half of OBGYNs. We're talking about North America, but I don't know how different it will be in Pakistan. And then, which physicians are happiest at work? %25. And we come to this stage. And we come to this stage, okay, how can we do that? And then, okay, the different ways, resources for healthcare, well-being, physical, mental, spiritual, original, environmental, emotional, and how can we do that? I think it's very important that you seek your oxygen. Keep yourself afloat, keep yourself functional, keep yourself so you can look after your family, your children, your future, and everybody has his own oxygen, like I have mine. And I personally feel that, I read books and I play with pets, and because my grandchildren are not in the country, so I look at them on the videos, and when I get too tired, I always say to myself, कैसे कह दूं कि थक गया हूं मैं, न जाने किस किस का हौसला हूं मैं. Thank you.